So as Francis has already introduced me, I'm a medical doctor working in Tanzania at the US Embassy at the Centers for Disease Control and Prevention. And what I'm going to share with you mostly will focus on my experience working with the PEPAR leadership program when I was working with another organization, international organization called ICAP. When the NJIA, the PEPAR leadership program phoned me and took me. So I will share the experience, personal experience, but again, the overall overview of the program itself. So to begin with, next please, can I control the slide myself? Do I need to point there? Okay, great. So to begin with, I'll give you the overview of Tanzania, overall healthcare in Tanzania. And when I was listening to the Prime Minister yesterday speaking about the move to the middle-income country, moving Uganda to the middle-income country, I was like, okay, that is the move in our country as well. So we are as a country, Tanzania, we are also looking forward to, going to the middle-income country by 2025. That is the motive that our current government under the President Magufuli has. And we are hoping that will be, enriching and benefiting the healthcare system overall. Tanzania, you all know about, is one of the East African countries, certainly the biggest, as you see. We are 55 million people currently. The population growth rate is a little bit high. But the most important is the parameters that defines our country, which is related to the services, quality of services that we are supposed to be delivering to the people. So the GDP growth per year is 6 to 7%, and the GDP spent on health is, in average, is around 5.6%. The mortality rate is 578. That's according to the most recent survey. And the HIV prevalence is 4.7. That's from the most recent Tanzania HIV impact survey that was published last year. So what I want to highlight on the HIV piece is the epidemic control target. I think she was speaking about the same, the 390s. So according to that survey, Tanzania is a bit lagging behind on the first 90, which is very critical. We are at 52% of first 90. First 90 means the people living with HIV who know their HIV status. So the idea is, the translation is 48% of the PLHIV living with HIV don't know their HIV status, and that is very critical in HIV prevention. I think we are almost the same with Uganda. Uganda is at 68%, 66%, I think, according to the FIA results. So talking a little about the Tanzanian health system, the strengths and challenges. Well, I was reviewing the World Bank report that was recently released, and it was speaking about good things about Tanzania, growing in different aspects. Maybe one more thing I would say related to the health system as a strength is the structure of health system we have in Tanzania. There's a very good connect between the central government and the local government. So central government talking about the ministries, the president's office, and going down to the district facilities and regions. So the administrative structure in our country, administrative unit, we have as a nation, and then we have subunits, which is divided by the region, district, and then we have the sub-district, we call them wards, going down to the streets. So we have leadership structures across. So for the health system, we have the ministry, and then we have the regional health management team, which receives information and directives from the ministry, and then trickles down those information to the district level. So we have the team called the Cancer Health Management Team, and down to the health facilities. So at each level, we had the leadership structures that, making the structure work in a very coordinated way. I would say that's the biggest strength. But then now we have the focus, not only, with the RBF that one of our colleagues presented yesterday, the initiatives of moving the leadership structure and administrative structure and management structure for health, not just from the health facility, but have another level between the district, cancer health management team, and the health facility in between, to have the structures at ward level, which is the subunit within the district, to be able to convey information and monitor the quality of health care deliveries at the community level. So there are those initiatives which are ongoing, which I would say stands as the strengths for healthcare system in Tanzania. So at every structure, at regional level, we have the regional medical officers, and has a team which represents every unit of healthcare delivery. And then at the council level, we have the district medical officers. In Uganda, you call them district health officers, I think. And then at the facility level, we have the in charges. So the communication between the ministry down to the facilities goes that way, and vice versa. So the reporting, the accountability from the lowest level up goes following exactly the same structure. So in terms of some challenges, these are challenges which faces most of the sub-Saharan African countries. The social shortage of healthcare workers, well, 56% might be critical, but that is, we have that cry almost in every country. And then what I would also want to speak about is how we select the health sector leaders. So, we have been discussing this as well across the sessions yesterday in different ways. But the criteria we use to select leaders is more of the technical expertise of those individuals. I'm a medical doctor, so when I'm good at my job, I'm likely to be appointed to be the facility in charge or the district medical officer, disregarding my leadership capacity, management capacity, my willingness at times. And these positions comes with some benefits, so we always go for them. So that is one of the challenge in leadership perspective that, how do we select leaders in health sector? But the last point is on the analysis of the impact and cost benefit of leadership. So we have been discussing this as well, that currently we have, the focus of health system strengthening is on leadership. And I think that's one of the recommendations I saw from the World Bank, that investing in human capital have impact not only in other aspects, but also in economic growth. So right now, we may want to have the proper analysis of the impact of leadership programs we are having right now to be able to inform the systems and the governments on how they can influence the policies and be mainstreamed into the operation health care systems as part of the valuable component which adds value in the quality of healthcare delivery. I was giving an example, and I talked to some people yesterday, that when we were introducing the leadership program in Tanzania, one of the questions we were asked by the RMO and DMO is that, okay, Oscar, by then I was one of the program manager that was taking lead to introduce the program in Tanzania. So the question which was asked by my friends, who are the regional managers and DMO, was, so Oscar, we have deficiencies. We have stockouts of drugs. Gloves is an issue. Medical supplies. We have very few beds. People are sleeping down, and you're bringing the leadership issue. Can you please bring those money to buy some other stuff? So the essence of leadership needs to be justified by. We need leadership. Regardless of that, we need leadership skills, leadership capacity to be able to monitor where those small resources we have to be more impactful than it is right now. So I will spend the next few minutes to describe the one disease that the PEPAL leadership program was focusing on in Tanzania, and that is cervical cancer prevention. So in 2015, the overall cervical cancer in Tanzania is somewhat mainstreamed to the healthcare system, but not given the respective priority. We have cases of cervical cancer which are very alarming, but then when it comes to the public health importance, it was kind of a disease which was, it's not given the, cervical cancer is integrated within the reproductive and child health service care delivery in Tanzania, but is not as prioritized as it's supposed to be. And we see the effect. 60% of the cervical cancer patients in Tanzania are diagnosed at advanced stage. And then almost 7,300 people are diagnosed every year, of which around 60% for the 200 die from the disease. So you can see the case fatality rate is also still very high. But again, with just the screening services, widespread screening services, we can save a lot of people who are at risk of getting cervical cancer. So there are ongoing efforts. To, by the country, supported by the donors, to deal with the cervical cancer in Tanzania, and one of them, the most recent, being the HPV vaccine, which has started most recent this April, and we are targeting to vaccine around 600,000 girls by the end of the year. So, speaking of the pillars of health system in relation to the cervical cancer. So when you look at the pillars, those pillars of health system strengthening, when you apply to each of the pillar the 5 why principle, when you ask yourself, so why this is not successful, every pillar will lead you to the leadership quality or leadership capacity component which is required to enrich or to capacitate that particular pillar. So we look at good service delivery. We have little motivation. Of course, there are issues of shortage of staff, but people need to be motivated to be able to do their job at the same state. And then we have issues of teamwork on health workforce. There are issues of feedback and team performance overall on the health information system. How does the information trickle from the facility up and up down to inform the decision-making procedures? And then communications. We have been speaking about communication most recently. Those are issues which, if you we receive drugs and that we don't communicate back, the stock status and everything, be sure that there will be discrepancies along the way. And then issues of influence and advocacy. So, the NJIA, that's the name of the leadership program that was implemented by PEPAL in Tanzania, Kagera. So the map you see On the top right, that's the Kagera map. That's where the NJIA program started. NJIA simply is a Swahili word, simply means way or path. So that was one of the leadership program that was meant to show ways on how leadership can inform the cervical cancer prevention efforts. And there were a lot of collaborators who participated in the program, led by the Ministry of Health itself, the government of Tanzania, and ICAP was one of the NGOs that participated, and other collaborators, as you can see. So what was it about? So the program was more of bringing together the international leaders from Roche, most of them are coming from Roche, and the Tanzanian healthcare workers together. Have them together as a cohort, let them think through the challenges that cervical cancer prevention faces in Tanzania, and come up with ideas and plans on how to solve those challenges in leadership perspective. And so far we have had 5 cohorts of the like, and 85 Tanzanians have benefited from the program, 85 international leaders, as well as 45 ideas have been developed so far. And these are the ideas that have been verified, analyzed. They're just there to be implemented, and some of them have already been implemented. And I would say for these ideas, we have Julie and Aruna, I think, who have been participated very closely. We have those ideas, and if they need to be shared, they can be shared. So lastly, this is the last part of my presentation. I will share my personal leadership takeaway and growth. Thank you. Yeah, so I have a few minutes to go. I will just go quickly. So my personal experience, well, I would say I learned a lot from the program itself. By the time I was joining this program, the NJIA leadership program, I was just promoted to be the regional program manager for the ICAP project in Kagera. So you can imagine, and I think by then I was one of the youngest program manager the organization has ever had in the country. So it was like, I'm a young person, I was entrusted by other people to do this, by my supervisors, my bosses, but then I was like, okay, how can I do this? So the good part is the leadership program, this leadership program came on time. And I would say, personally, it helped me very significantly into being, if I'm seen as a good leader today, which I believe so, is because I fall into the right hands of programs and people who nurtured me quite very well. So that's the cohort 1 of the NJIA leadership program, and the pictures on the right side is me. In Basel, we were doing the translation of cohort 1 to cohort 2, which is also quite very good, that you make sure that there is a continuation. That's why even today you can count 45 ideas. The reason is there is a continuation of handing over the cohort and ideas. So the last slide I would present is this one. So if there's one thing I would say to you that I've learned from the specifically NJIA program, which I have applied and I'm applying to date, is those 4 boxes. So balancing between being a doer, expert, achiever, and catalyst, the person who motivates others. So when I was very young then, I was given this big position. I was leading, I think, over 70 people under me. Was leading one of the biggest projects in ICAP then, $10 million project. So I was like, and when I was promoted to be the program manager, I was a doer. In fact, I was the technical advisor. I was always in the field doing the work. So I was like, this helped me to be able to balance. Now, how do I move from being a doer and expert to now go to the focus on the results and motivate people to achieve the results? So this helped me I would say very significantly, and is something, the model I'm applying to date. There are other, I wouldn't explain about the rest, but there are other models which I'm considering, I'm still applying, but then this is one thing that we should all focus on. Well, this slide just talks about what I've already explained. As the beneficiary, one of the beneficiaries of the NJIA program, leadership program, but also one of the young leaders in the health sector, I would say I have been blessed or advantaged by having the right people to nurture me through, that helped me also to be reflected right by the people who consider me, see me as their leader, give them the right inspiration, and also spend some time taking care of the people who I was supervising or leading, my subordinates. And I would testify confidently that to date, now I'm working with the US Embassy, but the good things that I've learned from other people, the good supervision, the good nurturing, the good hands that other leaders and supervisors gave me, those are the things I'm inspiring others. And I have people who I can call my children of leadership out of what I did. I have program managers and other people who are leading very key positions in different organizations in Tanzania, and they give feedback that, Oscar, we learned a lot from you, and I would say I'm so proud of that, and that's something I can confidently share and say it is very important to have the right people above you to nurture you through as a leader.